Thank you all so much for being here today. My name is Ashley Bramley. I'm the Community Relations Specialist at Grand River Health. Real quick, a couple housekeeping things. If you can silence your cell phones, that would be great. We do have some refreshments over here for you. And we also have some handouts up here regarding shoulder symptoms and just information in general. But today you are here to see Dr. Goldberg. He is one of our orthopedic surgeons, and he specializes in surgery, or shoulder surgery, shoulder pain specifically. And he is open to all of your questions. So I give you Dr. Goldberg. Thank you.
Hey, hello, my name is Dan Goldberg. I'm an orthopedic surgeon at Grand River Health. I'm going to talk a little bit about shoulder pain and some causes. Okay, so about me, I grew up in Spokane, Washington on the east side of the state. I did my medical school in Albany, New York, and then I did 5 years of training for orthopedic surgery at the University of Hawaii on Oahu. This is all training just in general orthopedics, so joint replacement surgery, trauma surgery, and then sports medicine surgery. I had a special interest in sports medicine and shoulder surgery, so I did an additional year of training at UCSF, specifically to train for shoulder replacement and then arthroscopic shoulder and knee procedures. I joined Grand River Health a year ago. This is our team. I think we got a great orthopedic team there. I continue to do just general orthopedics, so I do all types of orthopedic procedures, but still do have a special interest in shoulder surgery and sports medicine. So we'll talk a little bit about a couple causes of shoulder pain. The two that I want to focus on today are shoulder arthritis and rotator cuff tears. These are the most common reasons to have shoulder pain in anyone without a major injury. So I just want to start by talking about what is arthritis. We talk about arthritis a lot in various joints. These pictures here on the right are actually of a knee, but I think they demonstrate really well the arthritis process. So you can see this first picture here. That is fairly normal looking cartilage. Cartilage should be nice, shiny. It's what your joint uses as a surface to glide on. So between all the bones where you have joints, there's a cartilage surface. This is nice, healthy cartilage. You can see where they're pressing, it's a little bit soft. So that's the very earliest signs of arthritis, is some softening of the cartilage. And then over time, as you develop arthritis, the first thing you'll see if you look inside the joint is some fraying of the cartilage. So it'll start to fray and break down, and then eventually you'll start to get exposed bone beneath the cartilage. So this is more end-stage arthritis. And then eventually you'll totally lose the cartilage surface, and it'll just be the bones grinding against each other, and that's what we call end-stage arthritis. So the most common type of arthritis is just arthritis from overuse. It occurs with aging. Everyone at some point in their life will develop some degree of arthritis. Some people have more severe arthritis, either from overuse, or people are just more prone to develop arthritis than other people. You can also have inflammatory arthritis. You can have arthritis from previous trauma, but the most common type is just what we call osteoarthritis, which is wear and tear arthritis. So in the shoulder joint, what this looks like is you have the humeral head, which is the top of the arm bone, and that articulates with the socket portion, which is on the shoulder blade that we call the glenoid. So arthritis in the shoulder joint is breakdown of the cartilage at the top of the humeral head and on the glenoid, the cartilage surface on the shoulder blade. And it's the same process we were looking at in the knee, where you first develop a little bit of softening of that cartilage, and then it'll eventually start to crack and fissure and fray, and then eventually you'll wear off that cartilage surface completely, and that's that end-stage osteoarthritis. So the analogy we use a lot is like wearing out your tires. You know, originally you've got good full tread on the tires. That tread will slowly wear out, and then at some point you'll kind of be driving on the rims. That's when you get that bone-on-bone arthritis. Shoulder joint is same as the knee, where the most common type is just osteoarthritis, which is wear and tear arthritis. It's more common in laborers and people who overuse their shoulder. It's a bit more common in women. And then you can also have arthritis that develops from prior dislocations or other trauma, and arthritis that develops from inflammatory diseases like rheumatoid arthritis. Symptoms of arthritis. So what are you going to feel in your shoulder when you have shoulder arthritis? The main symptom of arthritis, and what sort of differentiates arthritis from other types of shoulder pain when we see people in clinic, is loss of motion. So as that cartilage surface wears out, you start to grind those bones on each other, and it becomes difficult to fully move the arm. Especially getting overhead is really difficult for a lot of people with arthritis. You also get pain in the shoulder. Pain at night is very common. Pain first thing in the morning, and then pain with activity are all symptoms of arthritis. And anytime we hear grinding or clicking, or you feel that sort of what we call crepitus, or that click, click, click as you move your shoulder, that is a sign that you may have arthritis in the shoulder joint. On x-rays, the x-ray on the right here, that is a normal shoulder x-ray. So you can see here is the humeral head. That's the top of the bone in the arm, the humerus. Here's the glenoid. This is the socket that sits on the shoulder blade. The space between them represents cartilage. You can't see cartilage on x-ray, but we know this large space here should have about 3 millimeters of joint space in a normal shoulder. That represents the cartilage. So as you start to develop arthritis, we'll see a few things. You'll start to thin out that space between the top of the humerus and the glenoid. You'll see these osteophytes or bone spurs develop. Those are outlined in red. The osteophytes are sort of the body's attempt to stop you from moving the arm as you start to develop arthritis. And then we can also see these cysts. Cysts are the bone beneath the joint surface, starting to see a lot of stress. So we'll see these cysts develop. And you can occasionally see narrowing of the superior space as well if arthritis is combined with rotator cuff issues. And then end-stage arthritis, as you get towards the last stages of arthritis, you'll see that joint space is completely gone. So that's what we call bone-on-bone or severe end-stage arthritis. This, you'll start to have severe loss of range of motion, pretty severe pain, and just difficulty using the shoulder. Eventually, you can actually start to get bony changes within the shoulder joint, so that humeral head that should be round is now starting to flatten. You'll get this very large, what we call a goat-speared osteophyte, and you can see just it becomes very difficult to move the shoulder without that cartilage surface and with those bone spurs impeding your motion. Treatment. So what do we do if someone first comes into the office with shoulder arthritis? How do we treat it? The first things we like to do are send those patients to physical therapy, especially in the early stages of arthritis. Physical therapy can be very effective in treating arthritis. The main goal with physical therapy is to try and preserve your range of motion. So as you develop arthritis, the body's going to be trying to tighten up that shoulder and keep it from moving. Our goal is to keep your shoulder moving and allow you to keep doing all the things that you want to do with your shoulder, especially that overhead activity. Also working on strengthening. The more you can strengthen the shoulder, the more stability you have in the muscles, the less stress there is on the joint. So strengthening can help decrease the pain that you feel that's associated with the arthritis. Injections. The mainstay with injections for arthritis is steroid injections. We use steroids in the shoulder similar to how we use them in the hip and knee. And they can help decrease that inflammation and help a lot with the pain that's associated with arthritis. And then activity modification. We'll talk a little bit about shoulder replacement surgery. The reason shoulder replacement surgery is much less common than hip or knee surgery, replacement surgery, is because it's much easier to just not use your shoulder. So when people develop hip and knee arthritis, it's very difficult to just keep living a normal life and not walk around on your hip and knee. If it's your non-dominant shoulder especially, it's very easy for people to just not use that shoulder. And you can do a lot of activity without ever bringing your arm up overhead. So the only surgery that we really have for arthritis in the hip, knee, or in the shoulder is joint replacement surgery. So this is a picture and then a radiograph of what joint replacement surgery for the shoulder looks like. The goal of the surgery is to essentially, we resect or remove the damaged portion of the shoulder, and we replace it with a titanium and then a high-density polyethylene, or a very high-density plastic that acts as the new surface for your shoulder to glide on. So this component of the shoulder joint is inside the bone. Then there's this smooth metal surface that makes up your new humeral head, and the glenoid, the socket portion, is replaced by a high-density polyethylene plastic. This procedure we use for patients with severe arthritis who failed conservative management. So if we try physical therapy, if we try injections, we try taking away those activities that you don't necessarily feel you need to do and you're still very symptomatic, those are the patients we recommend shoulder replacement surgery for. Typically, pain that prevents people from sleeping is really kind of what pushes people to undergo shoulder replacement surgery, or just an inability really to get your arm up above your head and be able to do activities that you want to do. So that is a brief overview of shoulder arthritis. Does anybody have any questions about shoulder arthritis or arthritis in general? No. Yep. So part of my fellowship was shoulder replacement surgery. I did about 100 shoulder replacements just that year in my training. So it is one of my favorite procedures. It's a really great procedure for people with shoulder pain, and we can get people back to all the activities that they like to do. All right, the next thing I'm going to talk about is rotator cuff tears. So this, other than arthritis, for older patients and patients with shoulder pain that's not from a specific trauma to your shoulder, this is sort of the most common reason for people to develop atraumatic shoulder pain. So I just want to start by talking about what is the rotator cuff. People are usually very familiar with rotator cuff tears, but a lot of times don't have a good understanding of the rotator cuff, what its job is or what it looks like. So the rotator cuff is a group of 4 tendons. All the muscles that send these tendons out start on the shoulder blade, and then the tendons attach around the humeral head or the top of the arm bone. They come across kind of like a sleeve. That's where we get the name cuff, is that it sort of sits surrounding the top of the humeral head. The main job of the rotator cuff is help to initiate shoulder motion. So anytime you start to lift the arm forward, anytime you start to bring the arm out to your side or back behind you, that initial motion is all started by the rotator cuff. It also helps to sustain the arm in activity. So anytime you're doing sustained overhead activity like painting the ceiling and you start to feel shoulder pain and fatigue, if you're trying to screw something in, like you're screwing that light bulb in and you start to feel the shoulder wear out, that's your rotator cuff fatiguing. And then the other job is it's what we call a dynamic stabilizer of the shoulder. So the shoulder is inherently a very unstable joint. We describe it sort of as a golf ball on a golf tee. It's a very narrow socket that this ball lives on, which is why you can move your shoulder in such a large range of motion. Compared to the hip is a deep socket. The reason you can't move your hip as much as you can move your shoulder is it's a much deeper socket than the shoulder joint. But that also makes the shoulder inherently unstable joint. So the rotator cuff, one of the main jobs is it sucks the humeral head down onto the socket, the glenoid, and it stabilizes the joint. And that helps the deltoid have a lot more power by stabilizing that lever, and also keeps the shoulder from dislocating. So rotator cuff tears, what are rotator cuff tears? The muscles, as they come off the shoulder blade, then insert and attach onto the humeral head. Over time, these attachments can wear out. I describe it sort of like fraying in a rope. Generally, people have atraumatic tears, or there's not some big trauma associated with tearing your rotator cuff. You just wear it out over time. So you sort of start to spray that rope out, and eventually it can fully tear through and cause a full thickness rotator cuff tear. You can also tear it in a big traumatic event, but most rotator cuff tears are not associated with a big trauma. So symptoms, what sort of separates when we're looking in clinic and trying to figure out, are you coming in and your shoulder pain is more related to arthritis or is it more related to a rotator cuff tear? The big difference is weakness. So people who have tears in their rotator cuff tend to have a lot of shoulder weakness, particularly with raising the arm out to your side and with turning the arm out to the side. You'll also have pain. The pain tends to be on the outside of the shoulder. You can also have a lot of pain in the muscles around the shoulder. So when your rotator cuff is torn or even when it's irritated, you don't use your shoulder normally. And patients can get a lot of pain in the muscles around their neck and also down here at the deltoid, because those muscles are all compensating for the fact that the rotator cuff is not working well. So someone who has a good intact rotator cuff, when they go to lift their arm, they bring it out nice smoothly to the side. For people with rotator cuff tears, a lot of times they'll kind of have to cheat their arm up, and that can lead to a lot of pain around the neck and pain in the back that can also sort of mask the fact that really what's generating this pain is a rotator cuff tear. And then we talked about with arthritis, you'll have a loss of motion. With a rotator cuff tear, in the absence of arthritis, you lose active motion. So you can't lift your arm yourself. If I went to pick up your arm, I could still get it all the way up over your head, but you would not be able to lift it on your own. And that's just because of the loss of strength. So people describe not being able to lift their arm up, but they don't have a true loss of motion. It's just a loss of active motion from not having the strength to bring their arm up. Rotator cuff tears. So the terminology we use for rotator cuff tears can be a little bit confusing. It's kind of a complex three-dimensional thing. So usually when we're talking about rotator cuff tears, there's a few sort of categories that we break it down into. The first stage is what we call tendinosis or tendinitis. This is when the rotator cuff is still fully intact, but the tendon is irritated and these fibers of the tendon aren't really healthy. So this is sort of like, if we're talking about the rope analogy, there's just a little bit of fraying in the edges, but the full rope would be intact. The next stage is you develop what's called a partial thickness tear. So this could be, 1/3, half, or 3/4 of the rope is now detached from the humerus here. But there still is a partial attachment of the tendon down onto the bone. This can happen both on the inside, what we call the articular surface, or the outside, what we call the bursal surface of the cuff. And we treat them a little bit differently, but both are similar pathology. And then finally, you can get a full thickness cuff tear where this tendon fully comes detached from the bone. This picture here shows, so when we talk about a full thickness rotator cuff tear, that means that from top to bottom, the tendon is torn all the way through. So you can see here, this is a full thickness tear, but it also has some width from front to back. So even if you have a full thickness rotator cuff tear, it still can have attachments either at the front or the back of the tendon. So it doesn't have to be completely torn to be a full thickness tear. It just, when we say full thickness, it means it's the full width of the tendon here, but it's not necessarily the full length of it from front to back. So on X-ray, an X-ray cannot show us really truly anything about the rotator cuff. We can see where the rotator cuff lives, which is in this space here above the top of the humerus and under the top of the shoulder blade, the roof of the shoulder blade we call the acromion. So the rotator cuff lives in that space there and attaches here on the what we call the Grayberg tuberosity, or the sort of the top of the humeral head there. Eventually, if you develop a large full thickness rotator cuff tear, then it will sort of pull away from the humeral head and the humeral head shifts up. So if you develop a large chronic full thickness tear, that we can see on X-ray because the space where the rotator cuff lives is no longer there. But for the vast majority of rotator cuff tears, we really don't see anything on X-ray. So since we can't see it on X-ray, our sort of imaging modality of choice is MRI, or magnetic resonance imaging. This allows us to see muscle soft tissue in addition to the bone. So on this image here, you can see the rotator cuff coming across here. In a nice healthy rotator cuff, the entire cuff will be this nice black line here. This particular sequence of MRI fluid is white. Anything bright that you see on the screen is fluid. And so you can see here, there's starting to have some fluid develop between the humeral head and the cuff where there should be healthy rotator cuff. So that represents a partial thickness rotator cuff tear. So this is sort of an early stage rotator cuff tear as the tendon starts to tear away from the bone. Eventually, this will progress to a full thickness rotator cuff tear where now you can see all the way from this space on the outside all the way to the humeral head. The rotator cuff is no longer attached. You see that bright white line going all the way through the width of the tendon. So this is now a full thickness rotator cuff tear. The last stage of rotator cuff tearing is what we call a retracted tear. So after this has fully detached from the bone, those muscle units are still active and they'll pull that tendon away from the bone. So you can see here, this whole space should be occupied by the rotator cuff, but it's pulled back away from its attachment, which should be here on the greater tuberosity, back to about halfway across the humeral head, and eventually it will pull all the way back past the socket. And that's when you see that empty space where the rotator cuff used to live, and that this is the type of rotator cuff tear that we'd be able to see on x-ray. But this is a very late stage, end stage, retracted rotator cuff tear. So this is a similar schematic to what we were looking at on MRI. It talks a little bit about the progression of rotator cuff tears. Once you develop a tear in the rotator cuff, it will never heal on its own. Those tears, once they develop, are present permanently, and they do tend to get larger over time. So if we take MRIs of everyone who has a rotator cuff tear and they just take them year after year, those tears will slowly progress. Everybody's tears progress a little bit differently in terms of the speed at which they progress, but the larger the tear is, the faster they tend to progress. So if you have a full thickness tear, it'll progress faster than a partial thickness tear. If you have like a large, complete full thickness tear, they tend to develop into those retracted tears over time. So that is the bad news about rotator cuffs. The good news is that even with these tears present, the vast majority of people, 75% of patients, can still get better without surgery. So what that means is you have a fully functional and pain-free shoulder. You still have that rotator cuff tear, but it doesn't affect you on a daily basis. So you can continue to do all your activity. You can continue to, do everything you like to do pain-free with a good functional shoulder, even though you still have a rotator cuff tear present. The mainstays with physical therapy for rotator cuff tears is a lot of scapular, parascapular muscle strengthening. So the idea is if you can keep your shoulder blade well controlled, it's less likely for you to sort of pinch that rotator cuff as you bring your arm up, and less likely to further irritate and further tear that rotator cuff. And then also rotator cuff strengthening to keep the intact portion of the rotator cuff functioning well. Injections for rotator cuffs, both corticosteroid or steroid injections are effective, as well as you may hear about platelet-rich plasma. Platelet-rich plasma works very well in decreasing the inflammation of the shoulder. There are some studies that say it may work a little bit better early on than corticosteroid. The unfortunate thing about it is most insurance plans do not cover platelet-rich plasma. So we tend not to recommend it. Corticosteroids in the long run work just as well as platelet-rich plasma, and they tend to be covered by insurance. So typically, if you come see us in the office, if we're just working you up for rotator cuff tear, you've tried some physical therapy and it doesn't work, and we want to try something else, typically the next step is we'd recommend a corticosteroid injection. And then similar to arthritis, we can recommend activity modification. So if there's things that bother your rotator cuff that you're willing to give up, that is one way to treat rotator cuff tear. For patients where those conservative measures fail, that's when we typically recommend rotator cuff surgery. The studies show that if you do a full 6 weeks of physical therapy and your shoulder has not improved to the point that you're happy with how your shoulder functions, continuing to do more and more physical therapy doesn't improve the result. So after 6 weeks, if you haven't improved, if you have that rotator cuff tear, especially a full thickness tear on MRI, and you want to discuss surgery, what we usually recommend is an arthroscopic rotator cuff repair. So arthroscopic just means we use cameras and small incisions to visualize the rotator cuff. We use a series of anchors and sutures to fix the cuff. So we'll put these anchors within the bone. Those anchors have sutures attached to them, and then we can use those sutures to pin the rotator cuff back to the bone. The first 6 weeks after rotator cuff repair, you're typically in a sling. The reason is that these anchors are extremely strong, the sutures are extremely strong, but the tendon itself is usually a little bit deteriorated if you have a rotator cuff tear. So this tendon can pull through those sutures if you try and use your shoulder too early after the rotator cuff surgery. So typically we spend about 6 weeks in a sling, and then we get you working with PT to help get first your range of motion back and then your strength back. This is a very effective surgery. The recovery is a little long, which is why we don't recommend it as a sort of for everyone with a rotator cuff tear. But it is very effective in treating shoulder pain and getting people back to doing all the activities they enjoy doing. This is a similar picture to that. This is just an arthroscopic picture. This is what we're actually seeing when we're doing the surgery and repairing the rotator cuff. The final thing I'll mention, so in these massive irreparable rotator cuff tears, this one I showed you where the tendon is fully pulled away and there's not really any more tendon for me to grab onto to repair back down the rotator cuff. There are various treatment options. These do sometimes respond well to physical therapy and injections. There are some newer procedures where people will try and add some patches here, but sort of the standard of care for these massive tears is just to do what we call a reverse total shoulder replacement. This is another type of shoulder replacement where we switch the ball and the socket. So typically the ball is on the humeral head and the socket is in the glenoid on the shoulder blade. By flipping these, it adds a lot of strength to the deltoid and allows people to function very well without a rotator cuff. So for people with these massive tears where the muscle has started to atrophy, the tendon is fully pulled away and we can't get it back down with those arthroscopic procedures, for those patients we recommend this reverse total shoulder replacement if they're not happy with their shoulder after trying physical therapy and injections. Any questions about rotator cuff tears?
What's the common cause of those injuries?
The most common cause is just aging and use of the shoulder. So similar to arthritis, if you MRI everyone over 65, up to 50% of those people will have some tearing in their rotator cuff, even though most of those people don't have any symptoms. So just like, your hair gets gray, our cartilage starts to wear out, and the rotator cuff over time for everyone will develop some small tears. For most people, those aren't symptomatic, but for a lot of people, it can cause shoulder pain. You can also have it with falls onto the shoulder. That's the most common cause of like a traumatic rotator cuff tear or like a fall where your arm gets pushed up. But most commonly, there's no trauma. It's just sort of a wear and tear phenomenon of wearing that cuff out over time.
So you mentioned the arthroscopy is not super common?
The shoulder arthroscopy, so this is very common. This is the most common procedure for rotator cuff tears. So aside from those massive tears that we can't repair with arthroscopic procedures, this is this is by far the most common way to treat a rotator cuff tear surgically.
Okay. And I can attest that mine held up extremely well.
Yep.
Does it stay just like that, or does anything dissolve?
Yes, these sutures are permanent. Once the tendon heals to bone, they're sort of just a bit of a reinforcement. They're not really necessary once the tendon heals to bone, but they do stay in permanently. They don't tend to bother people, and it is a very durable repair. So people who re-tear their rotator cuff after surgery tend to do it in the first 6 months while the tendon is still healing. But once the tendon heals, these last for a very long time. Oh, yeah. So this, again, this is a very common arthroscopic procedure. This is another one that we did a ton of in our fellowship training. We've been doing a lot of it here. Obviously, we've got a very active group of patients out here. And so a lot of people who've used their shoulder and abused their shoulder over time develop these rotator cuff tears, and this is a very effective treatment for it. All right. Well, thank you all very much for coming. I'm going to hang out. If you guys have any questions, I'm happy to answer, or we're, of course, happy to see you in our clinic.
Life is about movement, about seizing the moment, about creating memories that last a lifetime. But when pain holds you back, it's time to take action. At Grand River Health Orthopedics, our team of experts is here to get you back in the game, back on your feet, and back to what you love. Schedule your appointment with Grand River Health Orthopedics today. Because life is good. Live grand.